Welcome to the Explainer. Today, we're completely stripping away the noise to build your intensive care clinical intuition. If you've ever felt overwhelmed by the sheer volume of data at the bedside of a critically ill patient, you are definitely not alone. We're going to tackle that head-on using a high-density, modular execution protocol based directly on our core critical care sources. We're locking in the pathophysiology and the immediate clinical actions that separate a good clinician from a truly great one.
Here's our clinical itinerary for today's bootcamp. We're hitting ARDS physics, ventilator dynamics, acid-base vectors, and wrapping it all up with a rapid-fire validation drill. Let's go. All right, Module 1, ARDS physics and alveolar capillary permeability shifts. According to the source literature, acute respiratory distress syndrome is defined fundamentally by non-cardiogenic hydrostatic isolation caused by profound inflammatory exudation. Simply put, it's not a plumbing backup, it's a structural breakdown. Welcome to the judge's bench. This is where we aggressively filter out all that secondary noise to confidently isolate ARDS from standard cardiogenic pulmonary edema. Look at the key differences we've pulled here. You want to look for an acute onset right after a major insult like sepsis, bilateral ground glass opacities, and this is absolutely crucial, a PaO2 to FiO2 ratio of 300 or less. So what's your definitive diagnostic watershed here? It's the pulmonary capillary wedge pressure, or PCWP. If that wedge pressure is elevated above 18 millimeters of mercury, you're looking at hydrostatic failure, basically volume overload or a left ventricular issue. But if it's under 18, the plumbing is totally fine, but those capillary walls are actively leaking, leading to an endothelial permeability failure. Wrapping up this module, take a look at this pathology variance box in stark red, pulled straight from the ARDS-NET guidelines. Once you make that ARDS diagnosis, you have to intervene strictly. We're talking a mandated 6 milliliters per kilogram of ideal body weight. And yes, ideal body weight, not their actual current weight. Why? Because lungs don't grow when a patient gains adipose tissue. If you overinflate those fragile inflamed alveoli, you're literally going to cause catastrophic ventilator-induced lung injury or volutrauma. Your absolute goal here is keeping those plateau pressures strictly under 30 centimeters of water. Moving right along to Module 2, Ventilator Dynamics, Resistive versus Elastic Failure. In this module, we have to accurately separate airway caliber friction, which is just a tube issue, from alveolar parenchymal compliance, which is a lung tissue issue. Check out this chronology map. It perfectly illustrates the mechanical sequence of a breath, showing you exactly when these vital diagnostic pressure readings are generated in real time. At 0 seconds, the breath kicks off, forcing air through the endotracheal tube. Half a second in, you get a rapid friction spike, maxing out at your peak inspiratory pressure or PIP. By the 1 second mark, flow completely stops at end inspiration. The air settles into the alveoli. The pressure drops a bit, and at 1.5 seconds, it equalizes to the plateau pressure, or P-plat. That P-plat, that reflects the static flexibility, or the true compliance, of the lung tissue itself. And that brings us to the brilliantly straightforward pressure fork analysis. When that ventilator starts blaring at you, you check these two numbers immediately. If both the peak pressure and the plateau pressure are elevated, the lung tissue itself is stiffened up. That's a pure elastic or compliance problem. Think ARDS, pneumothorax, or pulmonary edema. But what if only the peak pressure spikes and the plateau pressure is totally normal? You're literally just fighting resistance in the tubes. Maybe the patient is biting the endotracheal tube, maybe there's a mucus plug, or they're having an acute bronchospasm. Our next pathology variance box highlights a screaming fundamental rule of the ICU. Always, always check the plateau pressure. It instantly tells you if you're dealing with a king-toes or a dying lung. If you're not doing an inspiratory hold to check this pressure, you are flying completely blind in your vent management. Next up is Module 3, Acid-base vectors and metabolic compensatory drift. Let's map out exactly how alveolar ventilation adjusts under the biochemical stress of systemic pH chemosensing. Listen, you simply cannot survive the wards without Winter's equation. It's a lifesaver. When a patient is in metabolic acidosis, their body naturally wants to hyperventilate to blow off CO2 and compensate. But how do you know if they are compensating enough? To find out, you calculate the expected PaCO2. You take 1.5 times the bicarbonate, add 8, and give it a plus or minus 2 buffer. If their measured PaCO2 is higher than that expected calculation, your patient is spiraling into a simultaneous, uncompensated respiratory acidosis. Their ventilatory drive is actively failing. Now let's categorize this metabolic onslaught with our severity invasiveness scale. The anion gap is your best compass here. A normal anion gap metabolic acidosis, like you'd see with severe diarrhea, usually buys you some time to find the cause and manage fluids conservatively. A high anion gap, that demands active titration, like giving insulin for DKA or getting source control for sepsis. But pay attention to that bottom row. A critical high anion gap, maybe with an osmolar gap from ingesting toxic alcohol like methanol or ethylene glycol, that demands immediate, highly invasive protocols. We're talking fomepizole administration and hemodialysis right now to prevent permanent organ failure or death.
Take a look at this clinical presentation from our sources. We have a severe sepsis patient with metabolic acidosis. Their measured CO2 is 36. But when you plug their low bicarbonate into Winter's formula, you see that their expected CO2 should actually be between 21 and 25. Since 36 is way higher than that, they are completely failing to compensate. They're actually in concomitant respiratory acidosis because of overt central nervous system depression and respiratory muscle fatigue. The numbers don't lie.
All right, Module 4, Validation Drill. Time for some applied simulation to lock this all in. We're jumping straight into 2 high-stakes vignettes to test your reflexes. Picture this. You get paged to the bedside. The vent alarms are absolutely blaring. You've got a 45-year-old female with severe pancreatitis. Her peak pressure is through the roof at 42, but her plateau pressure is sitting perfectly calm at 18. Based on that pressure fork analysis we just covered, ask yourself, is her pancreatitis triggering ARDS, or is this just a pure mechanical tube issue? By reordering these clinical findings into a real-world mechanical timeline, the answer jumps right out at you. Because that plateau pressure stayed completely within normal limits, her underlying lung compliance hasn't changed at all. The actual parenchymal tissue is totally fine. That sudden airflow obstruction jacking up the PIP? It just means she's biting the endotracheal tube, or maybe her airway is plugged with mucus. Knowing this immediately saves her from unnecessary, reactive, and frankly dangerous lung interventions.
Now for our second vignette. We have a patient with a history of infection, presenting with diffuse bilateral infiltrates and severe hypoxic respiratory failure. This is practically a textbook case of the Berlin definition of ARDS we went over back in Module 1, acute onset, bilateral opacities, and a clear non-cardiogenic mechanism. So faced with a rapidly dissolving alveolar capillary barrier and refractory hypoxemia, our protocol is definitive: urgent endotracheal intubation and mechanical ventilation. As you prep to execute those low tidal volume protocols, I want you to ask yourself one final question. Are your clinical reflexes sharp enough to catch this kind of respiratory collapse before the patient actually codes? That is the true essence of critical care intuition. Thanks for joining me on this explainer, and I'll catch you next time.